Thank you, everyone, for this generous invitation to join my colleagues in Armenia and around the world in sharing the latest in our field of epilepsy. I'm going to be talking today about the semiology in the adult population. I have no disclosures. I'm going to start with the concept of epilepsy, how it evolved from the concept of zones to network, and finally we're going to give cases that's going to elaborate certain semiologies, particularly the focal in the focal epilepsy. We're not going to address or delve into the generalized seizure types. So what is epilepsy? As noted here in the illustration, you have the picture A and picture B, where you see different presentation of what constitutes and what represents or what describes what epilepsy is. In the past, we used to think that there is a hypothetical zone that you have to resect enough tissue from that epileptogenic zone for you to attain seizure freedom. This zone includes, in addition, symptomatogenic zone where it causes the symptoms, the Ictal semiology. You have the epileptogenic lesion, and also the focus where the seizure started from. However, over the years, and especially with Dr. Susan Spencer, our concept of epilepsy has changed. And now we talk more about networks. And the reason why that's more relevant in the current practice is that with the newer devices, with the newer generation neuromodulatory devices like responsive neurostimulation or deep brain stimulation, and with also the newer neuroimaging techniques, we now know that it's more of a network theory rather than a just small focal area in the brain. So for example, you might have a hub or a node that might be instigating the seizure, but at the same time, this node might be connected to other nodes in the brain that might be in the vicinity or in the remote, and those can have variable degrees of connectivity, and those can be all of them involved in the seizures. So that's where our concept currently is, and there are more emerging data that corroborate this hypothesis. So case one, just to show you how we have focal findings, but overall we have a global or regional network problem. So this is a 57-year-old patient who has very focal seizures that progress to bilateral tonic-clonic activity. Over the 2 years' time, his epilepsy worsened tremendously. He was swinging between periods of repetitive cluster seizures, where he could have multiple seizures per hour, up to periods where he was in non-convulsive status epilepticus, and at times with focal motor status epilepticus. He failed all anti-seizure medications, immunotherapy, plasmapheresis, everolimus, which was administered because of a genetic mutation, DAPDC5, and also the biopsy, finally a biopsy showed that there is a left hemispheric Rasmussen encephalitis and focal cortical dysplasia. So what is the semiology? So let's dissect it for this patient. So there are 3 seizure types. So first, you have the déjà vu, sense of being in a dream, and this dizziness, as if he describes it, I'm fading out of sensation, I'm fading away, and he loses awareness. Looking at the semiology, it doesn't seem to have much of a lateralizing value, although that's not the rule, but sometimes you see déjà vu most likely associated with non-dominant hemispheric seizures, but it localizes mostly to the mesial temporal. Looking at his second seizure type, we see that there is the teeth. He reports teeth and his gums are becoming sensitive. The throat is itchy. Then this progresses to right-sided facial clonic movement, goes down to the neck, arm, and finally the leg. And post-ictally, he has right-sided weakness as well as excessive secretion in his throat, and his voice becomes weak. So looking at the sequence of events, mapping a trajectory, you would say that the seizures are likely from the frontal opercular area or the insula as well. And they progress and they march towards the primary motor area in the left hemisphere, specifically involving the facial representation, the moving more medially from the lateral to medial side, involving the neck, the arm, and finally the leg. The third seizure type is speech arrest. He comprehends, but he's unable to utter words. He has severe expressive aphasia, and post-ictally, he gradually starts to regain his language, and he has marked naming deficit. This puts us into the frontal dominant operculum, and because it's mainly the speech, and unlikely the comprehensive center in the temporal lobe, where you have the comprehension center. So this is the seizures, how their seizures look. As you see on the quantitative analysis, you see all these per hour. He has multiple seizures per hour. And this is the MRI. As you see here, there's hippocampus sclerosis on the left. You have some thickening of the cortex in the angular gyrus here, the possible dysplasia. And then finally, you have increased signal, the gray-white matter junction blurriness in the opercular area. And then you see it, this is on the volumetric analysis. You see this area is thicker in the opercular region and the insula compared to the other side. So basically with this patient, you see it's a broad, although you have certain areas of semiology that are involved, but they are in different anatomical locations as well. So it's probably multiple areas of ictal onset. So this is at the start of his epilepsy, you see a nice language mapping. All these areas are involved in the language task, where he was able to perform expression, he was able to talk, and it was he was okay. This, you see, there's loss of language. Over the years, the tractography also shows that he has impairment. You have loss of signal. This is the start, and this is 1 year. Basically, the green, it means that there are tracts going from the anterior to from the posterior to the anterior part of the brain on the anterior axis. You have the red is goes to the from the lateral to medial or medial to lateral, and then the blue is just it's the marches down towards the brainstem. So if you see here, there is loss of signal in this area, which means that the tracts over time are being affected not only by his disease process as well, and also epilepsy can also be part of the etiology. So this is the PET scan during his seizures. You see the hypermetabolism in these areas. It's in the frontal area, specifically here in the frontal opercular region. This is the subtraction PET, where we use that between the ictal and the interictal, and you see it, it's a broad region. So how do you treat this patient? If this is a dominant hemisphere, you cannot perform resection, or else there would be a compromise. So we implanted it with deep brain stimulation. So the reason why I brought this up is because now with the era of neuromodulation, we're targeting the thalamus. So now we're talking about networks. We're not talking about mainly specific zones. We have a broad network where we're trying to modulate and trying to affect and subsequently attain seizure freedom over the long period of time. This is the area of the anterior nucleus of the thalamus. We have bilaterally implanted. This is the CT where you have the depth electrodes. And this is an interictal activity, which means that there are spikes we're seeing from the left thalamus. This is the right thalamus. As you see here, there are spikes that we see. And then here, this is a seizure that we see when the patient is having clinical seizure. The thalamus also records a seizure. As you see here, the seizure evolves, and then it's evolving, and then it's becoming more rhythmic. So the thalamus was not part of the lesion. However, since we have lots of connectivity with the limbic system, the frontal lobe, so we have it involved, and that's where our concept of epilepsy is changing and evolving. And as you see here, with there's more activity in the left, and there's no activity on much of the right side. So what is semiology? Semiology is a clinical manifestation of a seizure. It's the byproduct of a dynamic interaction between different parts of the brain, nodes and hubs within an epileptic network to cause the semiology. Now, semiology is a crucial key of evidence for localizing, lateralizing seizures, trying to see where exactly that part of the brain is involved in producing those symptoms. However, it doesn't necessarily mean that that's where the seizures are starting from. It might simply mean seizures start from an area that's very close or in a remote area, propagate to that specific region, and hence result in the semiology. So that's that's called the Ictal propagation activation of that area to cause this semiology. So what are the types of seizures? As mentioned, generalized and focal. We're going to address here for the focal seizures. Now, I tried to categorize the areas, the lobes of the brain into their territories where they can produce different symptoms. So, and as you note here, we have the insula. In the past, we never addressed the insula, but over time, we found out that most of the failures that we're having in the surgeries, and we're assuming it's probably frontal or probably parietal or even temporal, the main ones are the temporal, is secondary to an unexplored insula. And now we have more of, we're exploring that area more often and more diligently. So dividing the lobes, we have temporal, frontal, insular, occipital, parietal. The temporal, the reason why it's divided into mesial and lateral, because the semiology manifestation when seizures arise from specific areas differ. And we're going to address that in a bit. Frontal, we have the prefrontal part of the brain. We have the frontal operculum, as we saw in this prior patient where the language was involved in the dominant hemisphere. The frontal eye field, that's where you have the gaze deviation with the versive head deviation, the primary motor cortex, the premotor supplementary motor area. And as we saw in the prior patient as well, we had it involved with specific manifestations. The anterior insula, the posterior insula, totally different. Occipital, medial, lateral, infracalcarine, and supracalcarine. Infracalcarine and supracalcarine are a bit different simply because it depends on the propagation pathways. And again, we come to the concept of network. If the seizures are infracalcarine, then they can propagate down to the temporal lobe and cause different manifestations. If the network goes from the supracalcarine pathway, then we would have different manifestations like parietal frontal manifestations and more of motor features. Parietal, also similar to the priors, we have the inferior parietal lobule, superior parietal lobule, and we have the primary sensory and secondary somatosensory cortices. Always keep in mind with the semiology, when you read a paper, there are lots of papers out there. They talk about semiology and localizing it to this area, frontal lobe. So make sure that whenever you read those papers, you understand that they also have been associated with the seizure freedom, which means that if a semiology has been attributed to the mesial temporal, okay, did they study that in postoperative patients? Did they study that in patients who attained seizure freedom? If the semiology is coming from the mesial temporal area, they resected it, and the patient has attained seizure freedom, then yes, you can confidently say that the seizures are attributed to that area. However, if you do the resection and the patient does not attain seizure freedom and they have persistent seizures, then we should always question the validity of a particular semiology to be pointed to that particular area of the brain. And when I say that, I want to bring the simple example of gelastic seizures. With gelastic seizures, when they performed surgeries on temporal lobectomy or frontal lobectomy, the patient persistently had seizures, simply because the main area that was triggering and causing the seizure was the hypothalamic hamartoma. So that's what's important when we look into semiology, to assess their relation with the outcome as well, to confidently say this part of the brain is likely associated with this semiology. So what are the most important, key semiology features that we have to look for? Fear, panic, most likely mesial temporal, anterior cingulate, anterior insula, and to certain rare extents, the prefrontal and the orbitofrontal area. The reason why it's probably less likely is probably there might be a propagation from the anterior to the from the anterior insula to the prefrontal area, and hence we sort of attribute it going into that region. Autonomic feature is mostly sometimes comes from the insula, the temporal lobe, mesial prefrontal. Experiential phenomena is usually this deja vu-like feeling, or the complex visual hallucinations, psychic manifestations. Usually they point to the temporal lobe. The most important also is the déjà vu, the jamais vu, all these memory-related manifestation. They point to the mesial temporal area, the entorhinal cortex, and less likely to the anterior insula. Anything that's laryngeal, anything that has bilateral presentation, let's say chest, torso, along with sensory manifestation, is usually in the opercular insular region, posterior insula, and the parietal opercular region. Tachycardia, insula, and the temporal lobe. Hallucinations also has to be divided. If it's a simple auditory hallucination, it's likely the primary auditory area, which is the Hash's gyrus. If it becomes more complex, then it's the temporal neocortex. You have the illusions of the body, somatic illusions, vertiginous sensation. Those all point to the inferior parietal, temporal parietal junction. Visual illusions, otoscopy, macropsia, all these point to the parieto-occipital area. Importantly, the visual fields. So if you have a primitive visual manifestation, flashing lights, let's say flickers of lights, colors, those are most likely to the occipital lobe. And if they become more complex, they have, you see, for example, some patients say, I saw a castle. They all point to the temporal lobe or the temporal occipital area. Automatisms, they usually unlikely have a lateralizing or localizing value. Usually they say mostly temporal, or the in certain rare instances, the orbitofrontal area. However, the most lateralizing, highly lateralizing feature is the manual automatism that is ipsilateral to the seizure onset, associated with contralateral dystonic posturing. That's mesial temporal lobe. And the reason why we have ictal dystonia is because we have ictal recruitment of the basal ganglia. And lastly, the most prominent is the hypermotor gestures that point to the prefrontal cortex, like kicking, bicycling, pedaling, pelvic thrusting. Aphasia points to the dominant frontal lobe, dominant temporal area. You have the versive head turn. So if it's early on, versive head deviation, it has to be in the frontal eye fields, which is the posterior part of the middle frontal gyrus, and anterior to the premotor area, contralateral always. Motor movements, tonic, clonic, is always contralateral to the ictal onset. And finally, you have these other sensory manifestation is always contralateral to the primary sensory cortex. So let me give you some examples to go over the cases. We have a 26-year-old patient who had a seizure of the type déjà vu, swallowing movement, which are the oral automatisms, nonsensical speech, which means that it's not ictalophagia. He was able to speak words that are clear, but they were out of context, and that pointed to the non-dominant hemisphere, fumbling with the right hand, which also puts it to the ipsilateral side, and you have left hand shaky movement, and this is what we call it ringe, which is non-rhythmic, the non-clonic tremors of the contralateral hand to the ictal onset, and sometimes stiffening of the left hand, which is the dystonia, and also again is contralateral. So if we're going to, and lastly, the other part is the wiping of the nose with the right hand, which is usually a post-ictal phenomena associated with ipsilateral focus. So if we're going to localize and lateralize, we're going to say lateralizes to the non-dominant right hemisphere and localizes primarily to the mesial temporal structures. So looking at the mesial structures here, the hippocampi are normal. Intracranial monitoring, we see here the seizures start in the hippocampus in the right side, as you see here, and then they march backward and downward, producing the different other manifestations. So the seizures clinical manifestation starts at the red dot. As you see here, the seizure started, propagated, and caused the semiology. Now, surprisingly, our patient had also left-sided seizures on this side. So as you see here, but those did not have any clinical correlates with it. And this is not uncommon for patients with temporal lobe epilepsy. So then we stepped back and said, so this patient has right-sided seizure and left-sided seizures. The left were silent. In real life, what is he going to experience? So that's why the decision was made to implant him with a device. So this device, we call him the responsive neurostimulator, where you see there are electrodes directly going to the hippocampus. And as you see the electrodes here, they're in the hippocampus and in the amygdala. So basically these record the seizures. So the idea is both diagnostic and therapeutic. You see here, the right hippocampus is causing most of the seizures. So as you see here, the right side is seizing, the right side is seizing here, where the left side is not seizing. So the idea from this approach is to have a recording of the patient's real life seizures, to quantify them, to see if the left side is also causing seizures. Because if the left side is also causing seizures, then at this time, what we're going to do is we're going to either continue with the stimulation as we're doing here. The TX is giving treatments to every seizure that the patient has, or if there is only right-sided seizures, then we are going to offer him a resection of the right side if all the disabling seizures are proved to be right-sided seizures. This is another case, as you see here, in the temporal pole. The temporal pole is the anterior most part of the temporal lobe. It's in the neocortex, it's neocortical region, and it has high connectivity with the hippocampus. So if you see the symptoms, fear, depersonalization, oral and bimanual automatism, tachycardia, those all point to mesial temporal manifestations. However, the seizure starts from this area, propagates to the hippocampus, activates it with the Ictal pattern, and causes the manifestations. So if you see here, within the scalp EEG, it was right-sided seizure. And on this patient, what we did is basically we offered resection of the cavernoma in that area, and the patient has been seizure-free. So what was happening is that the patient had neocortical seizure propagating to the mesial area, producing the symptoms. Removal of the cavernoma caused the resolution of his symptoms. This is another patient we have, where we have the, as you see here on the right side, we have a thickening of the cortex. As you see here on the right side in the frontal opercular area, we had a thickening of the cortex and also some thickening in the insula as well. As you see here, this is the premotor region, where you have thickening of the cortex involving the facial area. And why is it important? That piece of information is because of his symptoms. So he has two types of seizures. One nighttime seizure, wakes up, has this unusual aura where there's a rush into his body. There's the gasp, he gasps for air, and has some quivering and spasm of the throat. If you want to localize this points you towards the insula to the opercular area. This is the type of manifestation that we have it from that region. The second manifestation is inner sensation in the left lower face, sometimes in the mouth, the tongue, and then he gets left-sided facial pulling, left shoulder and trunk twitches, and rarely progresses to bilateral tonic-clonic activity. Localization is, again, left going to be contralateral, which is the right-sided lower face, and then it marches upward gradually, following the homunculus, and goes from the face to the arm to the shoulder area, and then it is by hemispheric propagation. As you see here, the EEG, MRI manifestation corroborate all are concordant and they are congruent findings. You see here, it's all on the right, centroparietal, mid-temporal, and central region on the right. This is the intracranial EEG. Now, if you see here, roughly speaking, the lesion is around this area where you see it with the yellow circle. And the areas that are, this is where the seizure starts. And those are the nodes or the areas that are recruited. And those are the areas where they produce the symptoms, as you see. So the seizure starts from here, propagates, and produces those symptoms. So what we have done for the patient, now this is very critical, this is a motor area. So we cannot remove this area, although it's a right hemisphere and there's no language in that area. But since there's motor, we map the area, we draw the margins of the resection, and we ensure that the ictal onset area is involved in this. Those areas are for the critical for motor function of the hand, okay, and the arm. So we excluded these areas, and then this is the resection cavity. So last, we're going to talk about the parieto-occipital types of manifestations. A patient has flickering in his eyes, flashing lights, both visual field, his perception changes, has palinopsia, where pictures recede in an alternating direction, and they have oscillation, but no movement within the eye field. So all these manifestations, you see there's primitive visual and some movement to the vision. So this points to the parieto-occipital area. Then, as you see, the manifestations progress into oral automatism, left-sided non-forceful head turn, and then he goes into right-sided non-versive head turn, then progresses into bilateral tonic-clonic activity. So all these movements in the head, usually we say, because they are later in the seizure, it might not have a highly lateralizing value. However, the most important would have been a versive head turn. Versive head turn is usually contralateral, and we don't have this. One would assume in this way and say, possibly the seizures are propagating from that region that we have it into the bilateral temporal area, and hence we have all these manifestations. Okay, so this is the MRI. You see here that you have the cortex, the neocortex is thickened in the parieto-occipital region, superior occipital, inferior parietal, and it's a quite broad region. So we investigate that area to ensure that we know the margins where we're going to resect, especially that the semiology is rapidly progressing into bihemispheres. So if you see here, this spikes start from the occipital area. That's where the depth electrode is in this region. We implanted this area. So spikes start from there. And as you see, it becomes maximal, and the symptoms start here, which if I magnify it, it shows that there is a progression into most of the temporal frontal channels in the brain. This is the frontal part, and those are the temporal channels. So the seizure spreads out from the occipital parietal area down to the temporal and up to the frontal. And that's why it causes all these multiple types of manifestations. So as you see here, this is the onset, and it marches in the brain in different directions. And those are all contingent upon the connectivity of the brain. So the patient had a resection. This is the focal cortical dysplasia, the dysplastic neurons, and this is the region of the dysplasia. So what is the take-home message from this, from our presentation? Semiology is a very important key that helps us to lateralize and localize. However, we have to keep in mind, it does not necessarily mean the area of ictal onset. It might simply mean that it started from an area and propagated, activated, causing the symptoms. Always, when you're reviewing your seizures or assessing an epilepsy patient, you have to know your anatomy, you have to know your network, and you have to know your tracks. And finally, the most important thing, that as we are evolving in our concept, the thalamus has become now an important anatomical location where we are targeting it to modulate the networks in the brain to stop the seizures and hence to have a better outcome. I want to thank my collaborators who have helped me with all these cases and my team at Yale University. And thank you everyone for your time.